Well, thank you for coming. So I'm going to be talking for about 25, 30 minutes around drug use, young people, and the role of parents. And one of the things I wanted to do is challenge some of the thoughts that we have when we think about young people and drugs. So that's a little bit about me. I'm an addiction psychiatrist. I run a number of specialist clinics for young people. I also run a number of university clinics for university students. And of my national roles, the one I think that's important is I'm an advisor to government on drug harms. So I'm going to talk about young people drug use, how common it is, the sorts of drugs that young people use, and then some emerging trends. And then I'm going to focus a little bit more on the relationship between a parent and a child and how we might think about that in the context of either preparing a child for a world in which they're inevitably going to come into contact with drugs, or the situation where a child is already using drugs and actually that family dynamic is then under significant stress. How common is drug use? So this is last year drug use. So these are surveys where for different populations, how many of you have used a drug in the last year? So I'm going to start off and I'm going to give you the first one. So globally, if you ask 15 to 64-year-olds, this is United Nations data, 1 in 18 people will say they've used an illicit drug. What do you think that is for the UK? So it's 16 to 59-year-olds. More or less? So 1 in...
12. 1 in 12.
1 in 11. Ah, very good. Okay. What about if we went to children in the UK? 11 to 15-year-olds. So if 1 in 11 adults, what about it?
Are we counting vapes?
No, these are just illicit drugs.
Okay.
1 in 15.
1 in 8. So suppose we went to young people now. So that's the group who most commonly use drugs. So 16 to 24-year-olds. 1 in 5. Now, 1 in 5. So now to some people, 1 in 5 is like they're going, oh my God, that's a lot of people. And other people will go, well, actually, I thought all young people use drugs. And so, 1 in 5, that means 4 in 5 are not using drugs. So it's really interesting how you sort of think about the perception. Okay, is drug use getting more common, less common, or is it actually pretty stable?
Illicit drugs.
Illicit drug analysis.
I think increasing.
Mm-hmm. Increasing more common, yeah. So the sort of perception, if you sort of read the papers, it's either pretty stable or it's getting worse. And it actually, the answer to that depends on what timescale you look over. So if you look over the last 30 years, and I'll just orientate you to this, so just look at the top blue line. So this is any drug use, any illegal drug use. It's almost all cannabis, which is the burgundy line. But if you look over the last 30 years, so this is from 1995, drug use has actually been coming down quite nicely. And as a drug specialist, that was a really pleasing trend to see that going down. We thought, fantastic, we've got this sorted. It's just going to dwindle down to nothing. But then this happened. So about 2012-13, the trend reversed and it started going up year on year. And we were like, well, what's happening? So it's going down, now it's going up. Then COVID happened. And we had this again. So we now, because we've got some gaps in the data because of COVID, we now don't quite know what's going to happen next with this trend. Now that's 16 to 24-year-olds. Now very interestingly, if you look at 11 to 15-year-olds, so younger cohorts, again you can look at this gradual trend down over the last 20-odd years, and then you see exactly the same pattern, this inflection point where for some reason that we don't really understand, the use went up, and then it's sort of drifting down, but it's a bit unstable, and it's going a little bit up and down all the time. Now, those data are all talking about people who say they've used drugs, not talking about people who said they've had a problem with drugs. So the next question is actually, what about drug use versus drug harm? Because we've got to think of these populations as different. So let's just think about harm, because we can think about harm in lots and lots of different ways. So we can think about harm to the individual who uses the drug, and that could be physical harm, that could they've taken a drug and it makes them sick, or they're drinking lots of alcohol and it gives them a hangover. It could be social harm, so a young person might fail at school, fail their exams, or become socially isolated. Or it could be psychological harm from persistent drug use. And then there are all the other harms to other people. So harms to the family unit, harm to community from drug use, and of course the international drug trade causes huge amounts of harm on lots of different metrics, whether that's the environment, whether that's people trafficking, and money laundering and all the rest of it. So let's look at some harm data. So these are under 18-year-olds who have come and said, I've got a problem with drugs and I would like some help. So there are about 11,000 children in the UK who are in alcohol and drug treatment. That's actually a 50% reduction since 2010, and that's largely because the funding has come down, and so the access to treatment has come down. 2/3 are boys, average age is 16. Most people did not go, I've got a problem, can I have some help? Most people were referred either by education, social care, or criminal justice. By far the most common problem drug was cannabis. Almost all of it's cannabis. And then quite some way behind is alcohol, and then a long way behind is everything else. So these are under 18-year-olds. 80% started using substance before they were 15. This is a very vulnerable group. They've got lots of childhood adverse experiences. They've got lots and lots of high percentage of being in care. They're a very vulnerable, disadvantaged group. 50% have a mental health problem co-occurring with their substance use, and we'll talk about that interplay a little bit later. But the key stat I want you to remember is the last one. 80% completed treatment. So if you can get this group who's really disadvantaged, if you can get them into treatment, they do really well. And that's a message that often gets lost. But if you can get in early with people, then actually people do really well. So that's under 18, but what about over 18? So now I'm just going to orientate you to this. So this is all the people in drug treatment, and you've got the age bars along the top, along the bottom. So you've got 18, 19, then 20 to 24-year-olds, 25 to 29. It goes on up to over 70s, and you've got different colour bars. So the navy is heroin. The orange is alcohol, and then the other two, the green is non-opioids, and the burgundy is non-opioids and alcohol. But the thing I want you to take from this slide is the majority of people in drug treatment and alcohol treatment actually services, so in all addiction services, are there for heroin use. And that's a problem for young people. Because as we said, almost everyone in the young people service is using cannabis. And then we look at 18, 19, up to 24, there's no heroin at all. There's hardly anyone using heroin. So we've got a system that is devised for people using heroin that's not appropriate for young people who are not using heroin. So we've got a system that doesn't match young people's emerging drug use. So they're not using heroin, they are using cannabis, and this is something important about cannabis. So this is cannabis, the strength of cannabis in terms of its THC content over the last 50 years. So if you were a hippie back in the 1967, 68, your cannabis had about 2% THC, 2 to 4% THC in it. And what you can see is over the last 50 years, we've seen this steady increase and then suddenly this lift off in the percentage of THC in cannabis. So we're now up, here it's about 14%. There are cannabis variants now with 25, even 30% THC. So cannabis is getting more harmful because THC is the most harmful part of the plant. And at the time that it's getting more harmful, the public perception around cannabis is that it's safer. So we've got this really interesting disconnect around cannabis. So cannabis is something we really, really need to think a lot about. We could have a whole talk on cannabis, but I won't do that. Maybe that's the next book.
Oh yeah.
So young people use cannabis, but they also use a lot of other things. So again, I don't want you to focus too much on the drugs, on the lines, but each of these lines is a different drug, and it's a spaghetti junction. So young people get excited about a drug, then it goes out of fashion and something else comes in. Nitrous oxide, no one was using nitrous oxide, then suddenly it became the second most commonly used drug by young people, and then it's vanished again. So you see this very dynamic market where drugs come in and out of fashion, and the one that you read about in the press at the moment is ketamine. So there'd be a lot of talk about ketamine. And again, ketamine was not very popular, and then suddenly it's become a lot more popular. So I just want to give you the sense that the market's dynamic. The other thing about the market is it's changed a lot. So here we've got, in this graph here, the first time a new drug was detected on European drug markets. This takes us way back to 2005. And 2005 to 2010, we saw a handful of new drugs, each year on European drug markets. Handful of new drugs, and it was like, yeah, okay, we can keep check on that. From 2010, though, something really changed. And what changed was synthetic drugs began emerging in massive amounts. So you can see this bar graph just goes crazy. We get to 2014, we've got over 100 new drugs a year released on European drug markets. That's 2 a week. And this is from a situation where we had, 4 or 5 in a whole year. So suddenly the drug market is flooded with these new drugs. And as you can see on the panel on this side, there are all sorts of different synthetic drugs. There's synthetic cannabinoids, synthetic cathinones, synthetic hallucinogens, synthetic dissociatives. So we suddenly got this market where, since 2010, we've had over 1,000 new drugs released onto the drug market. So something very, very different to what we've had before. And the challenge for that is that sometimes these drugs are sold by their drug name. So TCB that someone mentioned is a drug that people will seek out. They'll go, they'll say to their dealer, yes, I'd like to have some 2CB. But the majority of these 1,000 drugs are just used as cutting agents. They're used to fortify existing drugs because generally these are more potent and more harmful. The other thing that's changed is the way that people buy their drugs. So again, if we went back 20, 30 years, it would all be dark alleys in Camden and, that's where you'd find your dealer lurking. But you don't need to do that anymore. So the first thing that happened was the dark net. The second thing that happened was the clear net with non-UK illicit pharmacies. But where it's all now is social media apps. So the majority of my young people buy their drugs on Instagram or TikTok or Snapchat. So this is, again, a really, really big change in how the market happens. Okay, so some key messages so far. Firstly, the market is very dynamic. Young people's drug use is very dynamic, changes all the time. And actually, young people are not interested in opioids. So they're sometimes unintentionally given them. They're cut in, and that's very, very dangerous when it happens. But they're not seeking out opioids, which is unfortunate because our drug system has been set up to deal with heroin, which is the main problem we've had over the last 40 odd years. And so it's not really set up for young people. Most people don't know what they're taking. So if I'm on call and I'm called down to see a young person who's taken a drug in A&E, the dealer who sold the drug won't know what's in it. The person who took the drug won't know what's in it. And of course, I won't know what's in it. So in this situation with this 1,000 new drugs swilling around and no one quite knows what anybody's taking. High levels of coexisting mental health problems, particularly trauma. And social media is transforming the drug market, and I think will continue to do so. So that's a sort of background. What I'm going to do now is talk a little bit more about, I suppose, the book and parents, and in a way why I wrote this book. And really I wrote it because I've seen so many parents over my career who ask very similar questions. And I thought, well, why don't we just put it all in one place so any parent who wants to read the book can access that information. And really I wrote it for two groups of parents. The first group of parents are parents who are worried about knowing enough about drugs because they know their child is going to come into contact with them. And they just want to be informed. They want to know what the risks are, what the dangers are, what they should look out for. The second group of parents are people who are really struggling. Their child is either suspected to be using drugs or is using drugs, and things are at crisis point. And so I wanted to try and answer the questions that those two groups had asked. So let's just have a look at this. So why are adolescents more likely to use drugs? Is your child more vulnerable? These are some of the questions that came up. Let's just think about answering some of these questions, how you might answer it or make an answer for a parent. Here is my brain slide. I am now beginning to sweat and feel pretty anxious. So I'm going to do this very simply. In fact, I could invite either of you to come up and do this bit of the talk for me. So this is brain development. So we're trying to understand why is it that young people use drugs more than any other age group? What is it about adolescents that makes them more likely to use drugs? Well, the first thing is about brain development. So we've got a very simple, well, actually rather beautiful image here. So this is a brain of a 5-year-old, goes to a 20-year-old. If the brain's green colour, it's immature brain. As the brain goes blue and into purple, it's getting more mature. And what we can see is the brain sort of develops from the back to the front, and the last bit of the brain that really sort of develops properly are the frontal lobes. And the frontal lobes are our sort of command and control centre. They're the bit of the brain that goes, is this a good idea? Let's weigh up if we should be doing this or not. So the adolescent, the rest of the brain is racing ahead, and the control centre is not yet really working. And that's one explanation we've got for why young adolescents are more impulsive and sensation-seeking. So this is one explanation, but there are some other factors that are important as well. So social or peer pressure, cultural factors. So in some cultures, subcultures, drug use is much more acceptable than in others. The availability, and I should add in the affordability of drugs, and then the individual child's vulnerability. And broadly, this will be their physical health, their emotional health, their social health, and their genetic vulnerability. And this is where we get into this very particular issue around drug use and mental health. And this is something that I deal with every day in the clinic. So the vast majority of my patients are using drugs and also have a mental health problem. They have a co-occurring mental health problem. Sometimes they started using drugs and the drugs caused the mental health problem. And sometimes they were experiencing a mental health problem and the drugs soothed that. And then they found that soothing effect so powerful that they kept doing it. Of course, the drug use then makes their mental health worse, and so you go around and around in this spiral. And the mental health condition I see most commonly is trauma. So a very large percentage of people who I see in my clinic have experienced really quite significant trauma for which they're self-medicating. When I do talks at school, I often ask children to see if they can make a sort of guess about what their individual vulnerability might be. And the easiest way they can do that is to think about their genetic tree, their family tree. Have they got, if they've got a family tree that's stacked full of people with alcohol dependence, stacked full of people with gambling disorder, stacked full of people with drug problems, then actually it does make them more vulnerable. And that's been proven very strongly. So the same amount of alcohol will have different effects and different risks for different children. And so beginning to think about that is a really good way to get children engaged in thinking about risk. So what should parents do? Well, here's the book. I love to say all the answer is in there, but this is a very, very complicated area. And of course, there's you can't cover everything in one book, but I've done my best to sort of give a framework for parents and to answer the common questions. So let's have a look at some of those common questions. So this is the first group of parents who I mentioned earlier. They say, should I talk to my child about drugs? What should I say? When is the right time to do it? Can't I leave it to the school? Won't the school do it instead? And actually, you know, schools do have to talk about drugs and do drug education. So why encourage children, parents to talk to their children about drugs? Well, and the first thing is actually parents' views really matter. I mean, parents often think their views don't matter, but survey after survey shows that actually what parents say does have a really profound influence on what their children do, and particularly at younger ages, so particularly younger adolescents. The second reason to do it is to destigmatise the topic. So if you've never spoken to your child about drugs and they end up with a drug problem at 15 or 16, they're not going to come and talk about you, because they're going to go, well, I've never spoken about this and now I've got a problem and it feels really, really difficult. If, on the other hand, you've talked about this already, you've got it on the table, and I recommend the age to start is about 11, 12, before they've come into contact with drugs, they will know that this is a conversation you're happy to have. And in destigmatizing it, it makes it much more likely that they're going to come and ask for help. And the third reason is information influences choice. And you could probably not pick a better topic for misinformation than drugs. So your child would be getting information about drugs from the school playground, from TikTok, from all sorts of social media, from the internet. A lot of it will be absolutely wrong. And so you've got an opportunity in having a conversation to give them some better information and signpost them to where to get better information if they want it. There's not the research to prove this yet, but there is a sense that maybe some early conversations may have a preventative effect as well. But that's perhaps something we could think about when we have the Q&A. So how do you have this conversation? You know, it's you know, there's a lot of people who've been parents in the room, and you know, there are some certain topics that you avoid at all costs. You don't talk to your child about sex. You don't talk about drugs. You don't talk about. So how do you actually do it? Because it's a difficult thing to do. So here are some of the things that I've sort of learned over the years, really, and this is sort of much of this is from my experience of listening to parents about what's worked and what hasn't worked. So the first thing is, don't feel it's got to be a high noon event. You're going to have one conversation, it's all done and dusted, I can forget about it now. Do set the scene. What you don't want to do is surprise your child by going, right, we're going to have the drug conversation. And they're like, oh my God, what's going on? So don't do that. Prepare them. Think about whether you want one or both parents involved. So, some families will only have one parent present, and they may even want someone else, another sort of trusted adult. Be clear what the conversation is about. I've got some examples in the book of some conversations that go really well, but also some conversations that don't go so well. And the ones that don't go so well tend to be quite short. They start, we need to talk about drugs. And within 30 seconds, it's like, oh, okay, so what would you like for dinner? And it's hard to keep on track, and it's hard to be clear about what you want to say. Be consistent, keep calm and listen. It won't be the first time a parent has started a conversation and their child's gone, oh, yeah, I've tried cannabis. And the parent's gone, oh, my God. So you've got to keep calm, and you've got to listen to what your child's saying. Don't accuse, don't interrogate, firstly, don't claim to know nothing. Because if you go, well, you know, let's have the drug conversation, but I know nothing about drugs, your child would reasonably question on what authority you're speaking to them. Also, don't do the opposite, which is try and be the hip, cool parent who goes, well, I know everything about drugs, and, you know, when I was young, oh, my God, you wouldn't believe it. Because also, the drug market has changed so dramatically, as I hope I've illustrated, that whatever experience that parent has, it's changed. Give information. Don't forget alcohol. Alcohol is the most common drug that your child will use. Make sure you leave time for questions. Be prepared for the tricky question. Now, what is the tricky question going to be? What's the question that your child's going to die to ask you if you're talking to them about drugs?
Have you done it?
They're going to go, so mum, so dad, did you ever use drugs? Now, if you haven't used drugs, that's a pretty easy question to answer. You just go, well, no, I haven't. If you have used drugs, you've then got a decision to make. And you need to make that decision before the conversation, because children are very astute. And if they spot you going, oh, well, you know, it's complicated, they'll call you out on it. So either you go, with younger children, often it's confusing if their parent goes, well, yes, I do. They'll go, well, why? I don't understand. So sometimes it's better with younger children than not. With older children, sometimes it can be a good way to get into a conversation if you have used drugs at some point in your life to say, well, yeah, I did, and this is what happened, and this is why I've decided not to continue. That's got to be a judgment that you as a parent make, but you've got to prepare for it, whatever you do. Leave time for further questions and finish with praise, because it will have been very stressful for you as a parent to have this conversation. But for your child, I guarantee it will be more stressful to have your parent talk to you about this. One thing I haven't got on this slide, which actually I always mention to school children, is make sure your child knows how to put someone in the recovery position. So when I'm doing talks to schools, I always have a big slide and do quite a lot of work about this, because I have, unfortunately, over my career, seen a couple of children who have, died because their friends, left them lying on their back when they were intoxicated on alcohol or whatever it might be, and they've choked on their vomit. And so knowing that your child will look after a friend and know how to put them into the recovery position is actually a really, really important thing to do. Okay. And then this is the second group of children. So this is, children who are using drugs or suspected to be using drugs, and the parents are really, really struggling to know what to do. So, how can I tell if my child's using drugs? What does intoxication look like? How can I tell the difference between alcohol and other drugs? Can I drug test my child? These are sort of common questions. So the first thing is puberty versus drug use. So this is a bit tricky. So I've got a table in the book. I've got the physical, social and psychological signs of puberty and of drug use next to them. And the point of doing this is to show that a lot of them are the same. So acne, poor skin, reduced self-care, excessive or poor sleep, changing energy levels. It's going to be quite difficult. So what should you look for? So in terms of physical things, you look for drug-specific signs. So sores around the mouth or nose, conjunctivitis with cannabis use. Obviously, if we're into injecting sites, then things are really quite difficult. From the psychological side, again, your teenager, irritability, anger, emotional withdrawal, moodiness, distractibility. I mean, okay, so you can imagine parents going, I think they're using drugs. I've seen a Bob Marley poster in their bedroom, and they're very moody. So, but the sort of things to watch out for, the unpredictability of the behaviour, self-harm, so cutting, burning, those are sort of things that should be a really sort of important flag to a parent. And then in terms of social things, changing peer group, experimentation with new fashions, social withdrawal, again, the sorts of things to watch out for. Too much or too little money, significant or unexplained deterioration in academic performance, talking about drugs on social media, not being where they say they will be. That's a really important one. And obviously paraphernalia of drug use on their possession or in their room. In terms of intoxication, parents often say, well, I thought they were drunk. I thought they'd been drinking. But actually, I'm worried now that they might be using drugs. And again, broadly speaking, you've got four drug groups. You've got stimulants, sedatives, hallucinogens, and some people also talk about dissociatives. Got some examples of common drugs in those groups. Stimulants, people would be agitated, restless, sometimes euphoric. The sedatives are perhaps slurred speech, unsteady when walking, giggly, disinhibited. The hallucinogens responding to things that aren't there. and the dissociatives, trance-like states. So one of the complexities of this is most young people don't just use one drug at a time. So they'll mix a stimulant and a sedative, or they'll mix a hallucinogen, dissociative, bit of alcohol, bit of this, bit of that. And so you end up often with this quite mixed, complex picture. So it's not always as simple as that, but this is a sort of starter. You can test for drugs. You can test in saliva. You can test in urine. You can do hair sample testing as well. Most parents, or many parents who come to see me who are worried about their children, have already purchased online tests. And their children have often purchased online fake urine because they know their parents have purchased the test. So you can go online and you can buy fake urine. If you put in cheat my drug test, hundreds of websites will come up saying how to do it. So the first point about this is that drug testing is not treatment. You know, this is not, all you're going to do is sort of hopefully catch your child out. And actually it's only helpful if you've got the consent of your child to do it. Because if you don't have the consent, it's going to be very difficult. The other thing is that drugs stay in the system for different lengths of time. So a heavy cannabis user, you may be able to detect drugs on the urine test for weeks. Cocaine user, it might be out in a day or two, and it'll show negative. So this can sometimes be helpful, but it's usually not as helpful as people think it will be. And then sort of finally, when should a parent see a specialist? When should they go, actually, this is enough now, I can't cope with this, I need support, I need an expert involved. And these are the sorts of things that I say. So any sign that the child's injecting, using a Class A drug, the child is asking for help, they're suicidal or self-harming, any evidence of even mild psychosis, extreme risk-taking, be that sexual risk-taking or driving while intoxicated, physical violence in the home, and I'm often actually really sort of troubled by the level of violence that some parents let which develops in the home, which parents sort of normalize. And actually sometimes one of the importance of the conversations is to reflect to the parents that actually just that's not normal. You know, that's not okay, that level of violence. Existing mental health problem, a previous drug problem which suggests this may be a relapse, a strong family history of addiction, parents and child unable to communicate, a rapid deterioration in academic, social or emotional functioning. So those are the sorts of things at which I think actually you've really got to get some help at that point. So some final thoughts. So drug use, as I said, has been falling over the last 20, 30 years, gradually drifting down, but we've had a recent increase in the number, the potency, the availability and the affordability of psychoactive substances. Cannabis is getting stronger despite the perception that the risks are falling. And if you want to try and support your child in preventing drug use or reducing the risk of them trying drugs, start the conversations early, provide accurate information and remain vigilant. If your child is already using drugs, stay calm. Try and find out what the underlying problem is, because in many cases they'll be self-medicating. Seek help, and as a parent, look after yourself, because it's probably the most stressful thing that can happen to a parent and a family unit. And so it's really important that the parents also just think about looking after themselves. So I'm going to finish there, and if anybody's got any questions, I'd be delighted to hear them. Well, I think what it shows is that when you think about harm, you're really thinking about two things that interlink. You've got the effects and the properties of the drug, and then you've got the effects and properties of the individual taking the drug. And it's the combination of these two that ends up with either a major problem or actually some people are able to use without much harm.
Exactly.
Now, interesting, when I talk to children, I tend to talk to them about, to help them understand drug strengths, I talk to them about alcohol. Because even relatively inexperienced drinkers know that beer is not as strong as wine, is not as strong as vodka. And so when you say to them, okay, so this pill that you may take on a Saturday night, it could be like taking a pint of beer, or it could be like taking a pint of vodka, but you don't know.
Yeah.
And you don't know until you've drunk it.
And that's the real problem.
Yeah.
You don't really know.
So what would you do? You'd have a sip. You'd have a little sip and just see, does that feel strong or not? And so that's some of the harm reduction advice that we give young people. Try and get them to think about alcohol, because they often understand that alcohol is sort of, there are different strengths, and then get them to apply that knowledge to illegal drugs. So firstly, it's quite helpful for parents to know their child's friends. So I always recommend when parents say, well, what should I do? Say, well, know who their friends are. Because the likelihood is if you're in a social network, social cohort where everybody's using drugs, the chance of you using drugs yourself is much, much higher. And you know, we see that in all sorts of different behaviours. If something is normalised within your social circle, then it becomes much easier to go along with it. So as a parent, the first thing you want to do is have a sense of who your child's hanging out with. Now, what you actually do about it, if they then choose to hang out with a group who you suspect are using drugs, or using drugs heavily, or using the types of drugs that particularly concern you, well, that's a tricky one. I mean, the starting point is a conversation, and that's why, you know, I all the way through the book I'm going, you've got to talk to your child, and the better that communication, the easier this is going to be. Because what you want to do is say, you know, I'm a bit worried about the people you're hanging out with. You know, I can see that, or I think they're using drugs. And they may go, well, they're not using drugs. Just because they look a certain way or they've got certain fashion, that's not what they... And you may be reassured by that or not. But it's about starting the conversation and beginning to understand the landscape in which your child is inhabiting. And so sometimes I suggest that the way to get into a conversation about drugs is to understand that landscape. So you say, you know, do you know anyone at your school who uses drugs? You know, who are the people that you're, you know, what have you heard about drugs? Is there someone in the year above? Sometimes they'll go, well, no one in my year uses, but there's a boy in the year above and we think he smokes. And so you begin to get a sense of the sort of landscape that your child is living in. And that's really, really important. One thing I've done in the book is actually I put lots of case studies in. And actually the young people who pick up my book, they go, oh, it's for parents, but they flick through it and they really like the case studies. They read these stories and the narratives are the bit that catch their eye, because they go, actually, that's really interesting. That story, that reminds me of someone in my school, or that reminds me of one of my friends. Yeah. So, I mean, there's a section at the end on treatment, and it talks about the psychological, pharmacological, and social treatments for drug problems. And of course, the psychological ones are firstly looking at if there's an underlying mental health disorder. So if someone's got a depressive disorder, anxiety disorder, and they're using some sort of psychoactive substance to treat that, let's get on and treat the mental health problem, because actually then they won't need the substance. But there's also a whole section on resilience and how you sort of help your child begin to think more about their responses to the world and how they can do that. Now, of course, with that brain slide, you know, when your frontal lobes are haven't yet caught up, and you're impulsive and you make rash decisions, and a bit harder to treat that. So we've got this moment, and we've got this interesting double whammy, really, because at the moment that children are statistically most likely to use drugs, the drugs themselves are also most likely to do damage to the developing brain. So we've got this really, really big issue that, you know, in that teenage years where all those neural networks are getting laid down, that's when they're most likely to use drugs, but it's also the time when those fragile neural networks are most likely to be damaged by heavy drug use. And so if I had a sort of magic wand, I'd get no one to use any psychoactive substances until they're about 25. And their brain was at least sort of fully formed. And I think that would be a great thing if that could happen. Not that it's going to. Well, treatment works.
Yeah.
So, I mean, that's the simple message, that actually treatment works. And the earlier you get someone into treatment, structured treatment, where it helps you sort of teach some of these skills, then the better. And I think one of the things I've always sort of rail against about drug treatment services is they wait for people to come. Adult drug treatment services, you can get seen very quickly, but you have to walk through the door of the clinic. And if you don't walk through the door of the clinic, you won't get any help. And it takes about 8 or 9 years statistically for a heroin user to go from their first use of heroin to walking through the door of that clinic. That's 8 years of damage. And I have always tried to sort of understand why we don't do more assertive, early attempts to engage people. Now, that's not always easy, because some people will go, well, I don't have a problem. But I do think we're missing a trick, and we do need to think about, getting in earlier, both in terms of age and earlier in the life course of someone's drug use. We maybe should stop there. Thank you all for coming. It's been fantastic. Thank you.